All right, welcome back. If you are joining us from the prior sessions, or welcome if this is your first session at our sixth annual Critical Access Hospital Virtual Conference, Stroudwater. So for rural hospitals, survey readiness extends far beyond compliance. It directly impacts reimbursement stability, operational confidence, and public trust. And many organizations approach survey preparation reactively, but maintaining readiness requires consistent operational discipline, leadership alignment, and ongoing accountability across departments. In this next session, Carla Brock-Wilbur, who's a principal at Stroudwater Associates, and Jill McCulloch, Director of Quality and Performance Improvement at Soldiers and Sailors Hospital, will share practical perspectives on how organizations can strengthen readiness efforts and reduce regulatory risks over time. Drawing from experience leading quality improvement, operational assessments, and performance initiatives across rural healthcare settings, they'll discuss common vulnerabilities that organizations face and the structures that help sustain readiness between survey cycles. And just as a programming note, we plan on having time for questions at the end of the presentation. You can post your questions using the Q&A function in Zoom. If you can't see it, sometimes it's behind the little more thing on the bottom. And then we'll address those hopefully about the quarter of at the end of the session. So with that, take it away, Carla. And Jill.
Thank you, Keith. Appreciate you for the introduction, and we are very excited to be here again this year for our conference and sharing a little bit about survey readiness with you. I am trying to move this down. There we go. All right. And as Keith had said, I'm joined today by our friend, Jill McCulloch from Finger Lakes Health, and we'll be talking with Jill in just a few minutes as well. So survey readiness, our objectives for today. So we want to define survey readiness, understand what survey readiness really is and why it's important for our organizations, reviewing the types of surveys that CMS provides for us, and then understanding how our surveyors are preparing before they come on site at our facility. We'll review state and regional 2567 survey deficiency data, which is a great resource for hospitals to understand what the surveyors are looking for in the region and in your state. And then go into how to build your survey readiness toolbox so that you can maintain survey readiness in your organization. So survey readiness is achieving and maintaining an ongoing prepared, and prepared is the key word. Prepared state in which an organization can confidently ensure compliance with regulatory requirements, patient safety, and quality standards. We have a polling question for you now. So how prepared do you feel your organization is for an unannounced survey today? And we'll give this just a second. All right. It looks like, well, it keeps changing just a little bit. Most folks feel they're somewhat prepared. It looks like 61% somewhat prepared, 25% very prepared. That's great. 12% neutral, and then 2% not prepared. Okay. All right. So why is readiness important? Well, for the health and safety of our patients, of course, our caregivers and staff. Today, as of January 2026, there are 70 million Medicare beneficiaries. And as the population continues to grow, we'll have many more Medicare beneficiaries. It's estimated that by 2060, there should be more than 93 million Medicare beneficiaries. Most of our organizations across the country do have a high Medicare payer mix, and so that can definitely impact in our financial have financial consequences if we are found to be deficient and have financial penalties at our organization as well. So readiness is extremely important for that as well. We have the impact on health and safety. If we have these critical processes like our timely assessments, medication reconciliation, infection control, and patient monitoring, if those are not followed appropriately, they can lead to worsening clinical outcomes and increased risk of harm if we are non-compliant with our standards, as things like safety events, falls, medication errors, hospital-acquired infections. It provides a poor patient experience if we are not ready. There can be gaps in communication, care coordination, and responsiveness can cause our patients to be dissatisfied and have lower trust in our organization. And then, as I had mentioned, survey deficiencies can lead CMS to sanctions, including the loss of our Medicare and Medicaid funding and fines. So again, that is a huge impact on the health and safety of our organization. It can promote higher readmission rates if we have poor discharge planning, and CMS is very focused on discharge planning these days, discharge planning and patient education. If we have poor processes, that may impact our readmission rates and also long-term health outcomes. Having good readiness impacts our staff morale. Our staff do not want to operate in a state of crisis or under corrective actions that can increase our staff burnout, resentment, and turnover. And then if you have, survey information is public knowledge, and that can impact our reputation in our community if we are known to have a poor survey. And then severe findings can also threaten the hospital's accreditation status. And that has to do with the ability to attract providers, patients, and funding. And we do not want to lose accreditation status. There are types of cost surveys: the certification survey, validation surveys, revisit surveys, and complaint surveys. And we'll talk a little bit about each of those. Our certification survey includes both the initial certification and recertification surveys. And CMS described these surveys as those that determine if a prospective, if this is your first survey, or your current participant in Medicare or Medicaid, meets all the applicable requirements for participation and evaluates that performance and effectiveness of the participant's care. So our survey is to really understand, are we adhering to what CMS says that we need to maintain our Medicare and Medicaid status? The validation survey, CMS uses validation surveys to validate the performance of an accrediting organization. So there are other accrediting organizations that a hospital can choose to use, such as ACHC, the Joint Commission, of course, CIHQ, and DNV. And CMS uses those validation surveys to validate the performance of that accrediting organization. Also, CMS selects providers or suppliers for validation surveys on a random basis. And CMS has also put in place measures to strengthen the oversight of accrediting organizations, specifically around mainly holding those accrediting organizations to the same standards as the state survey agencies, and making sure that they are addressing all the conflict of interest that they may have, and reporting those particular items. Improving the consistency is CMS's role there, to improve the consistency and standardization in surveys nationwide. So it's aligning more the accrediting organization survey process with what the survey agencies of CMS would then do as well. A revisit survey is one in which the survey team reevaluates a specific deficient area that may have been cited during the certification survey or something that was a substantiated complaint. The revisit survey verifies that whatever was previously cited has been corrected. And then a complaint survey is a place where we never want to find ourselves. That's conducted after the complaint is filed, which there could be an allegation of noncompliance with federal or state requirements or both. The state survey agency can conduct this complaint investigation as referred to by the appropriate CMS location, and then the approved state program or the state licensed program or the accrediting organization. So investigation into a complaint may or may not result in an on-site survey. It just depends on what CMS decides needs to be done. Full surveys, which are the certification and validation surveys, are always full surveys that assess the entity's compliance with all of the conditions of participation. Generally, our complaint surveys are and revisit surveys are more focused, but they can be expanded if the findings warrant further investigation into that survey. So a little bit about how your surveyor prepares. So surveyors, as they're preparing to come on site, they'll review information about your hospital. They'll look to see, do you have special features such as swing beds, psychiatric, rehabilitation, distinct part units, or off-site locations. If that's the case and a hospital has a provider-based off-campus department or remote location, the survey team is required to assess the compliance of all the off-campus locations that provide same-day surgery and all remote locations that provide inpatient services like psychiatric or the rehabilitative distinct part unit. If none of the off-campus locations provide surgical or inpatient services, the surveyors will select one off-campus location for inspection. Typically, that's what they do. They'll look at any of your prior application forms, previous survey results, and your plan of correction from any prior deficiencies. They'll look at licensure records, media reports, Facebook, any of the social media that's out about your organization, and then your own organizational website. The surveyors will prepare for observations, interviews, and record review. They can look at, they make observations as they're touring the facility. They can conduct interviews with your patients or patients' family members and staff, and then they will review some of your records as well. This is an example from QSEP about survey. So during this survey, a surveyor happens to notice a damaged blood pressure machine. During a brief interview with the nursing staff, it was revealed that the machine malfunctions frequently and has been broken many times in the past few months, preventing the staff from using it. One of the nurses tells the surveyors that the staff submitted numerous requests for it to be fixed, but no one seems to be working on the issue. So in this particular case, that surveyor is probably going to look at how you report broken machinery. Do you have PMs, your preventative maintenance? Are there stickers on your machines? And how often are these different machines being maintained and so forth? So they're going to dig into other records associated with this particular malfunctioning machine. Another example of what they may do during the survey, the surveyor looks at this particular incident log. They happen to find that there are several reports of medication errors related to antibiotics. Two of the errors were not caught in time and did cause harm to patients. So while at the facility, the surveyor conducts interviews with pharmacy staff and with the staff involved in the patient care. And during those interviews, the surveyor learns that the pharmacy is using a new label and a new barcode system, but the staff claimed that they were not trained on how to read the new labels before the implementation. So during this particular situation, the surveyor may then look at training logs to make sure that the staff are being trained on any changes that are made that have to do with medication administration. Statements of deficiencies are what we call 2567. These are different deficiency data that are available for skilled nursing facilities, hospital, and critical access hospitals. These are, that's just the number associated with the official document that does have your statement of deficiencies and plan of corrections attached to it. And so when our state agencies conduct surveys for acute, critical access, psychiatric hospitals, and they're looking at, of course, the compliance with all of our regulations, the conditions of participation, they'll they prepare and provide a survey report on what's called a 2567. And this information is publicly shared. So it's broken down into the different conditions of participation and then the tags that help the surveys identify certain regulatory deficiencies. And that way our hospitals can then take this report that we're given and work from that report to understand what deficiencies the surveyors have found. And that way we can create our own plan of correction based on these 2567s. Again, this 2567 information is really valuable for you guys, and it's available publicly. It can show the standard level deficiencies, condition level deficiencies, and then, of course, the highest, which is immediate jeopardy. So there are two different citations that you'll see in the deficiency data. A standard level deficiency means that the hospital may be out of compliance with one aspect of the regulation, but it's considered less severe than a condition level deficiency. A condition level deficiency means that the hospital is not in compliance or in substantial compliance with the entire condition of participation. So there is a difference there. And then the immediate jeopardy arises when surveyors determine that a hospital's deviation from that regulatory standard really does constitute immediate threat to our patients' health and safety. And so that would force a hospital to correct these underlying problems immediately or face termination from CMS. This dashboard shows all of the different hospital deficiencies for the time period, and this is shown on the 2567 data. The hospital's deficiencies for up through May, or the middle of May. And as you can see, when you look here, there are 3,008 hospitals, and those are critical access, other rural emergency, and then non-rural hospitals that have deficiencies. And out of these 3,008 hospitals, there were actually 35,498 deficiencies. And of course, you can see the top is compliance with 489.24, which we'll talk about a little bit later, but that has to do with EMTALA. And so you can see on this dashboard the information that shows the top deficiencies, and that's throughout. That's all hospitals as well, not just your cause. This dashboard shows the critical access hospitals and then other rural hospitals and rural emergency hospitals. Top 10 deficiencies. Again, compliance with 489.24, medical screening, patient care policies, sprinkler systems, nursing service, electrical systems, QAPI, hazardous area, and then infection prevention and surveillance and control of hospital-acquired conditions, and then subdivision of building spaces. So those are the top 10 for just rural. That shows a little over 1,000 hospitals with a total of 3,342 deficiencies. This lists those particular top 10 deficiencies and the distinct count. So, top 10 patient care policies, if you look at the distinct, and this is just for cause, the distinct count of hospitals, there are 291 hospitals with 443 deficiencies in patient care policies. So that's something that can key you into, wow, if they're finding that many problems in patient care policies, then maybe we need to really focus on that particular area. So it's really good to look at what the top 10 deficiencies are showing for critical access hospitals and then kind of plan around that to make double check those areas to make sure that you are in compliance. These are about tag descriptions. So C tags are the regulatory citations that are used during survey, and that has to do with critical access hospital. If it was a acute care hospital, non-critical access, those would be A tags. C tags are associated with our critical access hospital conditions of participation. And some of our COPs, like provision of services, patient care policies, has 9 tags. So there are many different tags that can be picked up from the particular condition of participation. And we'll talk about the C tag 1006. So C tag 1006 is from 485.635A. That's your condition and standard, and that's the standard patient care policies. And it goes into all of the information about the cause health system, and healthcare services are furnished in accordance with written policies. And so the interpretive guidelines tell us that we must have written policies governing the healthcare services of the CAW, and that those policies must be consistent and applicable with our state law. And then it goes into what surveyors will do. So surveyors will verify that the CAW has written policies that cover the healthcare services that are furnished at the CAW, and they will also observe the staff delivering healthcare services to the patients and see if the actual provision of service actually is consistent with what our written policies say. And many times we find that there are numerous policies within an organization, but the policies are not consistent with what's being done. We see policies that specifically mention certain types of supplies or medical equipment that we no longer use, or that the policies reference national guidelines that are historic guidelines that have not been updated. So surveyors will look at a lot of policies and make sure that our policies are written, they're timely, they're dated, they reference nationally regarded guidelines that are up to date, and that we are actually doing what our policy says we are doing. This dashboard shows the different deficiencies within EMTALA. So you can see here, this is critical access, other rural and non-rural hospitals. There are a total of 1,238 hospitals with over 4,700 deficiencies just within the EMTALA space. A 2400, a tag for acute care, and C 2400, the tag for critical access hospital, speaks to compliance with 489.24. And again, as we saw earlier, that seems to be the number one non-compliant deficiency that we see currently. And that has to do with the special responsibilities of Medicare hospitals in emergency cases, of course, EMTALA. So that's one of the areas that they find lacking, CMS does, are the different tags within and the COP and standards within EMTALA. So that's something that we really should be up to date on. CMS does not typically come in and specifically look for EMTALA violations. So that's really something that you need to be a little bit more focused on yourself. But if they do see anything that is suspicious, then they will investigate it, of course. But we want to make sure that we go through all of the EMTALA guidelines and that we're up to date there as well. Here's an example of one potential EMTALA violation, the refusal to provide medical screening. So this particular patient arrives at the ER complaining of chest pain. Because the patient appears disheveled and mentions not having insurance, the front desk staff turns the patient away and advises them to visit a free clinic across town. Why is that an EMTALA violation? Because we must provide medical screening exams to any individual who presents to our ED requesting care, regardless of their insurance or appearance. Denying or delaying an MSE can violate the EMTALA Act. Delaying care for registration. In this case, a pregnant woman arrives at the ED in active labor. Instead of immediately taking her back for triage or evaluation, the registration clerk insists on completing all of her paperwork and obtaining that insurance information. Again, EMTALA prohibits us from delaying medical screening exams or stabilizing treatment to inquire about insurance or payment information. So using the data to address the top deficiencies in your state or region, that helps us to understand what seems to be falling out as non-compliant in our state and region. And it can help you prioritize the efforts that you need to place in potential organizational compliance gaps. Say you find, oh my goodness, these are different citations and deficiencies we see that, we might need to look at that because we haven't checked that in a while. So it helps you prioritize those potential organizational gaps. And it can help you be proactive in preventing and mitigating these deficiencies before your survey occurs. And it can help you to tailor your training. Maybe you realize that we need more training in high-risk areas. We can actually create a targeted, proactive action plan to address specific deficiencies and improve our overall compliance throughout our organization. So we have another polling question number 2. I'm waiting for the polling question. I think we have polling question number 2. Okay. There we go. So what area causes your team the most survey anxiety? Documentation, staffing competencies, environment of care, policies and procedures, patient rights, or infection prevention. We'll let this go for a minute. This will be interesting. Everybody has so many different focused areas. Okay. Right. Well, it looks like the top is policy and procedures, not surprising. Then documentation, followed by staffing competencies, and then environment of care and infection prevention are tied, and then patient rights. Great. Okay. So my friend Jill McCullough from Finger Lakes is here with us. And I wanted to ask Jill, before we came on site and worked with you, What do you really think was the most concerning area for you?
Overall, it was almost every area because you don't know what you don't know. So, although we always think we're preparing by looking at the standards and making our own plans, having somebody else come in to be able to look at everything and have brand new, fresh eyes that knew exactly what to look for, brought a lot of things to light that we would not have seen on our own. So, initially I would say maybe our biggest thing might have been environment of care, but after we were done, that moved down the list compared to other things.
Right. And didn't you guys, I think in May, didn't you just have a survey or
We
several
did.
surveys for your organization, right?
Yes, we had 5 surveys in 4 weeks. The first one we had was our critical access hospital survey by the New York State Department of Health. And thanks to having Stroudwater come in, I want to say you came in, well, about probably a year before we were
Mm-hmm.
expected, but it was late.
Hmm.
But it was funny because our staff, after our actual survey, said the Stroudwater survey was much more complicated and thoroughly done because we treated it just like a regular survey. We took all of the recommendations and anything they found that could be a potential finding and made a work plan just like we would with a regular survey, and then continued to work on those things right up until the time we had the survey. And we only ended up with 2 environmental findings and no clinical findings.
Perfect. That's great. And did you find, I know that most of the time in my past experience, the staff, I felt like if we did a lot of mock surveys and, tracers and that type of thing, they felt a lot more comfortable talking with the surveyors before, um, when they came, because it can be very nerve-wracking.
It is. You're right. Yes. And we used a lot of the tools that you gave us. So once we knew, especially where our areas where we could be most vulnerable, I mean, we created some of our own questions, but we used a lot of the things that you had and the tools for what the surveyors would be looking for and shared those with the staff. So it wouldn't be a surprise as to what the surveyors were looking for and what kind of questions might be asked. So they really felt a lot more comfortable, well, as much as comfortable as they could be. But they felt more comfortable talking to the actual surveyors because they had already gone through the process. And that's what I was saying. They felt like doing the Stroudwater survey was more complicated. They felt so much more prepared, and they were able to answer the questions without any problem when we had the actual survey.
Great. That's nice to hear. Thank you, Jill. I
Thank
appreciate it.
you.
Yeah. All right. So now we'll talk a little bit about building your toolbox so you will be prepared for the survey. So there are basically 6 key tools. There are a lot of tools out there, but I like to really focus on these 6 tools in preparing for your survey. So utilizing your past survey plan of correction, that's key. They will go back to your plan of correction and come back in to see if you are doing what you said you were going to do last time. And then maintaining a document checklist and assign owners. We'll go through each one of these. Developing a revolving calendar to make sure we have our policies and procedures reviewed and revised timely. Conducting internal tracers, conducting a daily checklist is important, and then potentially designing and print a pocket guide for your staff. So based on your past plan of correction, and this is an example of one where the regulation was this straight off of a CMS survey. The regulation was outlined in this particular one. It had to do with drugs, biologics, and intravenous medications administered under the supervision of the registered nurse, doctor of medicine, osteopathy, or where permitted by state and local physician assistant in accordance with written and signed orders and accepted standards of practice. And they said that the standard was not met. Based on document review, observation, and interview, the facility did not adhere to the protocol used for administering a aerosol generating treatment. So this was a technique for administering medication into the lungs. So the hospital's plan of correction was it was determined that nursing staff needs additional education on the proper administration of aerosol therapy, and to ensure ongoing compliance, we'll develop an audit process to assess whether proper elements of performance are being followed during the administration of aerosol therapy. And they had, beginning in December, audit 22 audits will continue for 6 months or longer if needed to achieve 100% compliance for 3 months. And then audit results are being reported to the chief nursing officer. So the surveyors will look at, did you do that? Did you provide education for your nursing staff? Did you begin audits? Did you do your audits for 6 months or longer to achieve the 100% compliance for 3 consecutive months? So make sure that your plan of correction is being done. We've seen many plan of corrections in our time that we go back and we say, okay, you said you were going to do this, and it's not being done. Or it was done for a while, but then we went back to old habits. So it's important that you review all of your past survey plan of corrections. The next part of the toolbox, maintaining document checklists. So there are a lot of documents, and you know that CMS will ask for a list of documents when they come in. To be ready, let's keep our document checklist up to date. Divide all of these different areas into categories and assign an owner to each one. For instance, you may have general organizational detail, and you assign that particular part of the document checklist to an individual or individuals, and they keep that up to date, so that anything that changes within this organizational detail is up to date, and we don't have to go back and look for it. Once the surveyors come in, we can have that person that is assigned to the general organizational detail bring their detail with them. Meeting minutes and reports. They always look at different meeting minutes and different reports from those. So somebody needs to be responsible for that. All of your plans and policies, all of your contracted services, any logs that you have, all of these different areas can be given ownership, and that way we're not having to search for all this information when they come in. So for example, under meeting minutes and reports, that person assigned to that area would get all of the med exec meetings up to date, P&T, board meetings, quality committee meetings, all of your fire drill documentation, infection prevention or antibiotic stewardship. This is just an example of the different types of things that you can do. You can divide it up however it works well for your organization, but maintaining all of the documents, keeping them all up to date, and assigning owners for each one will make it easier to pull all this together, keeping that notebook together or that little file box together when the surveyors ask for these documents. Developing a revolving calendar for policy review and revision, however it works for your organization. Maybe you have a calendar that start in January, you're going to do all the human resource policy review and revision, and then February environment of care, March, whatever works for your organization, making sure that that keeps us on a schedule and we keep up with all of these policies, procedures, and the revisions of those. Very rarely do we go into a facility and find that all of the policies are up to date. But keeping them up to date by breaking them down in snippets is a lot easier than saying in September, all policies have to be reviewed and revised. So breaking them down into different owners for each month works very well. Conducting your own internal tracers. Our leadership can select tracers monthly based on high-risk areas, sentinel events, or regulatory focus. They have a survey team that they pull together to observe the care processes, interactions with staff, looking at protocols. This team documents their findings, and then you review these and you develop your own proactive plan of correction. So you follow the path of the patient from admission to discharge and evaluate, hey, in each place that has a procedure or a policy reflective, then are we doing what we said we were supposed to be doing? It helps you to understand how you're translating these policies into practice. And it can help you identify gaps that you can then put a proactive plan of correction in place. Creating your daily checklist. There are so many different things that we know we need to check on a daily basis. Medications, our nutrition area, making sure your dirty utility room is clean, only dirty, and the clean is only clean. Your patient rooms, your medical record check, and so forth. Assign different things to different people. One day you may have someone who is, during the huddle, you say, okay, today you're going to go check our med room. Make sure it's locked. Make sure that the medication refrigerator thermometer is set to where it, and that we're checking it. We have all of these different areas. If we create a daily checklist and assign owners to do different daily checks, then we'll stay up to date on the different areas. And then designing a pocket guide. I think Jill's organization had a pocket guide at one point. I remember seeing it, and it was great. It talks about the mission, vision, values, different things that have to do with human resources, unacceptable abbreviation, all of the emergency codes. These pocket guides can be really valuable for your staff. They're small little pocket guides. They stick them in their pocket. I know our organization had one years ago, and it was really handy for our nursing staff and any of the floor staff to look at. If they were asked a question, they could remember what the answer was to that question. It had potential survey questions in it and helped you to navigate where certain things were. And it helped the staff feel a lot more comfortable by having that information right in their pocket, and they could review that prior to survey and stay up to date on that information. Failing to prepare is preparing to fail. I love that quote by Benjamin Franklin. So having your proactive plan of correction is good for your risk mitigation and regulatory compliance. It's cost savings from prevention of all of these different problems that could occur, efficiency and staff readiness, and it provides the ability to address core quality issues. So as you prepare for survey and become survey ready, you continue to address your proactive plan of correction, put plans in place. It may be something that you have to work on for a while, but you already have that proactive plan of correction in place. And if surveyors do come in and you show them your plan, surveyors are more likely not to cite you from something that you're already working on. So identifying your core issues within your organization and creating your proactive plan of correction is key for you to maintain your readiness. Now we have a couple more polling questions, number 3 and number 4. So questions 3 and 4. After today's session, how confident are you in your organization's survey readiness? Does it help you? And then the next one is, would your organization be interested in a mock survey or readiness assessment? It looks like it's still moving. Okay. How confident are you in your organization's survey readiness? Somewhat confident, 58%. Very confident, 24%. Neutral, and then a 1% need additional support. Would your organization be interested in mock survey or readiness assessment? 61, not at this time. 23, maybe, would like more information, and then 16, yes. Okay, thank you guys. All right. All right, we have a time for questions, I think, Keith.
You all done, Carla?
Yes, yeah.
All right, folks. You have in the Q&A, we've got some questions here for you.
Okay.
Let's see. If you had a past POC, is that also available publicly?
If you had a past plan of correction,
Yeah.
yes, they will show for now. If it's Joint Commission or DNV or another accrediting organization, that may not show in your 2567 deficiency data. But if it is straight CMS, that plan of correction will show, yes.
Okay. And then another question is there somewhere we can ask survey agencies in our state a question in regards to a regulation? And as in I am looking at regulation 666 and I interpret it as X, but my colleague is interpreting it as Y. Is there a surveyor or a place where we can ask for an interpretation?
Yes, your state survey agency should show up on the web, under CMS state survey agencies. But I will tell you recently, when I have posed questions to some of those individuals, there's been a lot of change in staff. I will say that. So I'm very happy. You can send me a question. I'll look at it for you and give you a response to that, or look at your state survey agency's website, and they should list the people within the state agency that can help you with your COPs. But if you have a question, please send it to me. I'm happy to interpret that for you.
Okay. And then another question, do critical access hospitals have any other tag groups that are required to follow other than the C tags? For example, do any A tags apply to cause?
A tags, no, but there are K tags. K tags have to do with your environment of care, like your physical space and your fire and safety and that type of thing. And then your EMTALA tags are different as well, but A tags don't apply to a critical access hospital. It's your C tags.
Another question is, this is a EMTALA question. On a pregnant patient, can I do a version of a triage, such as vital signs and pain, et cetera, to decide if I need to register them as an outpatient for reasons such as contractions or emergency for reasons such as high blood pressure?
Absolutely, and that happens in many organizations that do have an obstetrical department, where they do triage them and determine whether they need to go to the OB department or not. At that point, you're not delaying care because you're already checking vital signs and to determine, do they need to go on to their OB department or stay in the ER. So that does not appear to be a delay in care when you're already trying to assess them.
Okay. Are there any mock surveys available?
We do mock surveys. Stroudwater does mock surveys, and many organizations create their own mock survey. That Jill was describing what we did for them, and that was a mock survey. Her critical access hospital asked us to come and provide a mock survey and then give them feedback so they could get ready for their real survey. So that's what we do, and we're happy to do if you're interested. Or hospitals sometimes decide they want to create their own mock survey using the CMS conditions of participation.
Let's see here. Do you have survey readiness checklists you can share with us? We currently do mock surveys, but additional learnings are always welcome.
Oh, absolutely. Yeah, if we have your email, I would be more than happy to send out a checklist that we have pulled together.
Okay, good. And is there a link to where we can find our deficiencies from the last surveys?
We can send that link out to you too. It is publicly available, and we'll make sure and send that link out with all the information. Yep.
Yep. I think that's all the questions for now. Does anybody else have a question? Please put it in the Q&A box there.
We're happy to entertain any questions that you have.
All right. Somebody share their email because they would like a list of questions for the mock survey as well. We will get those out. All right. Anyone else? Any questions? All right. Looks like that's it. If you have any more, you can go ahead and put them in, and or you can email Carla directly, and she will be able to answer them. So I want to thank you, Carla and Jill. This is an important discussion around proactive survey readiness and organizational accountability. So as a reminder, let me make sure nope, not missing it. Okay. Everybody's very interested in the mock survey checklist. So, all right. So as a reminder, when you exit today's session, you're going to receive a brief survey pop-up, and we truly appreciate your feedback for this. It helps us to plan for next year's session, and it'll take you about 1 minute to complete. So please do that. If you're joining us for our final session of the day, you'll return to the conference lobby and then select that session from the agenda. And we're going to begin that at the top of the hour. Our final session today will focus on the high impact operational and financial levers rural hospitals can use to strengthen long-term sustainability and performance. And that is with Eric Schell and Dan Given from Stroudwire. So thanks again, Carla and Jill, and we hope to see you again at the top of the hour.
Thank you all.
Thank you.
Thank you.